All right, good morning, everyone, and welcome to day 2 of the Georgia OBGyn Society and Georgia Section ACOG clinical sessions. My name is Adrienne Zertucci. I am the chair of the Georgia section of ACOG, and I'll be your moderator for today. All right, let's go ahead and get started. So we are kicking off today's meeting with a panel discussion highlighting several cardio-obstetric programs developed by members of our very own GOGS leadership. Cardiovascular disease remains a leading cause of maternal mortality in our state, which underscores the urgent need for novel integrated approaches like theirs, aimed at improving outcomes for pregnant patients across the state. On our panel today, we have first Dr. Teresa Byrd, in the middle, who currently serves as the Residency Program Director in Obstetrics and Gynecology at Wellstar Kennestone Regional Medical Center. She holds a faculty position as Clinical Associate Professor with the Medical College of Georgia at Augusta University. She earned her Bachelor of Science in Biology and Pre-Medicine from Florida A&M University, and then her Doctor of Medicine from Meharry Medical College, and her Master of Science in Clinical Investigation through a joint program between Meharry and Vanderbilt. Dr. Byrd is a board-certified OBGyn via the American Board of Obstetrics and Gynecology, and she has built a distinguished career in both academic and clinical medicine. I'm also personally very grateful that she made the excellent choice to give me a pass when she was one of my own oral board examiners. Dr. Jane Ellis is a professor and eminent physician in the Division of Maternal Fetal Medicine at Emory University in Atlanta, Georgia. A Georgia native, she completed her BS, MS, and PhD at the Georgia Institute of Technology before earning her medical degree at Emory University. Dr. Ellis remained at Emory for both her residency in obstetrics and gynecology and her fellowship in maternal fetal medicine, joining the faculty in 2005. She currently practices at Grady Memorial Hospital and serves as the obstetric medical director for the Emory Regional Perinatal Center at Grady Health System. She is a founding member of both Georgia's Maternal Mortality Review Committee and the Perinatal Quality Collaborative, and is truly a force to be reckoned with when it comes to maternal health and healthcare in Georgia. Finally, Dr. Chad Ray, on the end there, is a professor of obstetrics and gynecology at Augusta University, the home of the Medical College of Georgia. He earned his undergraduate degree from the College of Charleston and graduated magna cum laude from the Medical University of South Carolina College of Pharmacy. After working in both retail and hospital pharmacy, he returned to MUSC for medical school, graduating in 2002. He completed his OBGYN residency at the Medical College of Georgia, where he served as administrative chief resident. Since joining the Augusta faculty in 2006, Dr. Ray has held numerous leadership roles, including residency program director, vice chair for education, and interim division director for obstetrics and general gynecology. He has been recognized as a Castle Connolly top doctor since 2014, and he served as the 2018-2019 president of our very own Georgia OBGyn Society. As an ACOG officer, I'm also personally incredibly excited that Dr. Ray has taken his skill set out of Georgia as well, and he's serving as our scientific program chair for and planning what will really be an incredible ACOG District 4 annual meeting this September. And that's in Greensboro, if any of you want to join us. All right, well, it says that I'm supposed to welcome you to the stage, but you guys are already here, so let's welcome them from the audience, Drs. Teresa Byrd, Jane Ellis, and Chad Ray. And as a reminder, please hold your questions until the end of the discussion.
Good morning. Just gonna see. All right. So I'm going to start off talking about cardiovascular screening, and if you guys have not heard about cardiovascular screening, I'm going to ask you probably to take out your phones and open them to your cameras, because I'll have a few QR codes here during the presentation. So in my role as one of the maternal co-chairs for GAP-QC, and I'm also on the Hope for Georgia Moms Task Force, we started thinking about ways that we could decrease maternal mortality. And you guys know cardiovascular disease and cardiovascular events are the #1 killer of moms, specifically Black moms in Georgia. And this was a specific interest for us. And so we started looking at ways that we could potentially decrease this maternal mortality rate, and that's where the focus of the screening came in. I also serve as the physician on the Physician Advisory Committee for CareSource, and I'll mention something about them a little bit later. So today we're going to talk about cardiovascular screening and the settings for use in pregnancy and postpartum, and then discuss ways to implement the screening inpatient and outpatient. And then we'll talk about what we did with the Georgia OBGYN residency programs in OBGYN, family medicine, and hopefully in emergency medicine to implement cardiovascular screening. So California is way ahead of us in the way of looking at maternal mortality and cardiovascular disease. And when the MMRC in California looked at their deaths, they actually created an algorithm that they applied to the deaths in their state and found that 88% of the cases of maternal mortality would have been identified before they died had they applied this screening tool. And then the detection rate increased to 93% when they included only patients that were symptomatic. So because of this, once it got published, that came from Dr. Afshan Hamid at UC Irvine. ACOG actually endorsed their screening tool. So if you don't know, you should probably screen that QR code if you're taking care of obstetric patients. Scan the QR code, and that'll take you directly to the screening tool. But they endorsed this screening algorithm. There are two versions of it. They're basically the same. The one on the left is the CMQCC, what I call the two-step protocol, which screens patients, again, in pregnancy and postpartum, up to 1 year postpartum. The second version was endorsed by the American College of Emergency Physicians, and the only real difference between the two is they included more symptomatic patients that have acute symptoms of chest pain, so they also included a troponin in that. And so that's the real difference between the two. And to simplify it for everyone, it goes through a number of risk factors, vital signs, and physical exam findings, and basically triages patients to get a next step EKG, BMP, so B-type natriuretic peptide, and then troponin, and potentially a chest x-ray. So really focusing on identifying patients with either heart failure or cardiomyopathy, and a subset of patients with a pregnancy-associated myocardial infarction. So really the focus is trying to identify those patients at highest risk of cardiomyopathy and heart failure. And so you may have seen some of these outside at the GAP QC tables, but these were things that we just created to simplify the screening tool so that you can post it in places and use it. So these are some of the ones we created. We also created badge buddies. So for my residents and faculty, we just put them on badge buddies so that they could easily look and then be able to screen patients very easily and not have to go find the piece of paper or something to go look it up. Another thing we identified is once we started screening patients and giving, letting patients know about warning signs, is we had people that were referring patients to the ED, be they midwives or doulas, were telling patients, you have symptoms, you should probably go to the ER, and patients were coming back saying, they didn't really do anything, or they didn't draw blood work, or if they did draw blood work, some of them did not get a BMP. And I'm just gonna say, in all of this, for me personally, really looking to decrease maternal mortality, my goal was just to see how many women can I keep alive, right? Yeah, we can optimize their health care, but we can only optimize it if they're still alive. So if these patients are at highest risk up to 1 year postpartum, what can I do? And one of those things you can do is order a BMP. If a B-type natriuretic peptide is going to be the one thing that helps you identify a patient with a cardiomyopathy, please just think about doing it. But so we actually gave the patients the language in this card to take. So these are patient-facing cards that you give them, and if they have symptoms, you tell them when you go to the ER, give your provider this card to tell them, consider ordering an EKG, chest x-ray, BMP, and troponin. So we tried to, through GAP QC, we tried to have webinars and get people and people like us who are a little bit older to start screening, and it just wasn't happening. Dr. Kotke and I were time and time again saying, who's screening at their hospitals? And we would get crickets on the calls every time. So being the program director that I am, I always have captive people that I can volunteer into doing something. So I basically said, why don't we just have the residents start to screen? And also as the current education committee chair for GOGS, I'm in touch with all the program directors for the 6 programs in the state of Georgia. So we decided as a group to say, why don't we all start screening patients in our clinics. First of all, we have the highest risk patients, more than likely, because all the patients get referred that other people don't want to care for necessarily or that don't have any resources. It's a mix of both community and university programs. We have scholarly activity needs. You guys know as residents, we're all required to do some type of QI or research project. Residents are usually eager, especially if you have some that are interested in going into fellowship. And then we basically put together a shared protocol and got data help from DPH and from GAP-QC. And this was just showing the names of the people who were directly involved at each of the institutions and the residents that were involved as well. So we got everybody on board, implemented the same protocol over a timeline. And so basically, starting at the beginning, we educated our trainers, our residents, and our faculty. Then after that, we started the data collection at the same time, July 1 of last year. And for 6 months, we started screening patients on postpartum day 1. And if the patients got admitted during their pregnancy on antepartum day 1, we also screened the patients to see if they were at risk. And so we have some preliminary data here. I'm happy to say that of the 5 programs that screened, we have a total of 1,307 patients that were screened, or 1,307 screens that were performed. And some of the common themes that we found are some of the vital signs, risk factors, or symptoms that were more prevalent were chronic hypertension, which we expected, a history of substance abuse, so be that alcohol or drugs or tobacco. Also, systolic blood pressures over 140, really stressing the importance of being able to have patients monitor their blood pressure, and of course, obesity, so pre-pregnancy BMI greater than 30. So these are the results according to, each different institution, because we wanted to see kind of the difference between them. And there were a couple of things that were striking. So on the left, we had an overall screen positive rate out of all 1,307, 17%, 230 patients screen positive. And one thing I want to highlight here in this part is just that only 2.6% of the patients were referred to cardiology. And this was a little bit striking to me because even if the patients ruled out for cardiomyopathy, it's clear by the risk factors that we just outlined in the slide before that many of them very likely probably need a cardiologist. And it's actually pretty well known in the cardiology world, and it's been published that women that have had a history of hypertensive disorders, specifically during pregnancy, severe preeclampsia during pregnancy, and even in more than one pregnancy, with mild preeclampsia, those patients have abnormal hearts and are at significant risk of cardiovascular disease later. So all of these patients, we should have seen probably a 17% referral rate to cardiology, so this is something that stood out to us. We did have 4 patients total with true cardiac events that were identified, so 2 with cardiomyopathy, 2 with heart failure, and then 9 other cardiac conditions that were identified. On the right-hand side, you have it all parceled out by institution. And what was striking is that Atrium Navicent had a 30% screen positive rate. So 30% of their patients were screening positive. But when we also looked at the difference in their demographics and things like BMI and hypertension rates, those were higher as well in that category. But in general, MCG had about a 19% screen positive rate. Savannah had a 12% screen positive rate, Wellstar had a 3.9%, and Morehouse a 4.4% screen positive rate. What we found too is that in some of the programs that were doing a better job of ordering those BMPs, and that's something that we wanted to highlight kind of for the next go round to ensure that once the screen is done, the patients are actually getting the tests that are recommended. And then there are also a number of patients that were identified with kind of high BMPs, and then again, not actually translating into cardiology referrals either inpatient or postpartum. So those are some of the things that we're looking at for future study. And then looking at the demographics, again, one of the things we wanted to highlight is the mean BMI, pre-pregnancy BMI for the patients was in the overweight or obese category. So that's a really important factor that we identify. And then also for patients that screen positive, those patients were more likely to be Black, 66.6%, be obese, with a BMI of 32.3 plus or minus 17, and then have a systolic blood pressure that's greater than 140, and substance use disorder as well. So looking at these risk factors, really important to kind of know your patients and look and see if you can identify them. So basically, we did this study. We are working now to get the data published, and then we're going potentially into phase 2. So one of the things that we wanted to do is we also recognize that maybe we weren't identifying patients at the right time, and so that also kind of pushed us to include our family medicine and emergency medicine colleagues as well. And so what we did was we invited our colleagues in emergency medicine and family medicine. There are 18 family medicine programs in the state of Georgia. There are 5 emergency medicine residency programs in the state of Georgia. And we had them come together because as we heard yesterday, basically Dr. Brown told us that about 18% of the patients that deliver in the state of Georgia actually are delivered by family physicians. And we all know that most of our patients are not coming back to see us postpartum, but they are going to see our family medicine colleagues to either manage their chronic hypertension, their diabetes, or to see their children. And so we wanted to get them involved as well. So what we did was focusing here on the fact that over 70% of the deaths in Georgia happen postpartum. And so we realized we're probably not identifying the patients at the right time. So now the next phase is we have included our family medicine colleagues, and as of July 1, all the OBGyn residency programs in Georgia are screening in the postpartum setting. So at postpartum visits up to 6 weeks postpartum, we're gonna collect that data. And also the 18 family medicine programs are in the state of Georgia have a collaborative and a grant, and they have all signed on to also simultaneously screen patients for cardiovascular disease in the postpartum setting, at least for up to 6 weeks postpartum. And our goal is that we identify women at highest risk of cardiomyopathy and heart failure and hopefully intervene before it's too late. So I'm really excited about this. This is the next step. We also have engaged our emergency medicine physicians. Their screening is gonna look a little bit different, but we have started to educate them, and we have had this information in cardiovascular screening presented on a national stage by one of their colleagues in emergency medicine, so we're really looking forward to that as well. And so lastly, I'm just gonna put a plug in here that take a second on this slide. If you have no idea about any of the screening or haven't done it, go ahead and take a screenshot of each of these to take you to the links here. The first is the cardiovascular toolkit that California came up with. The second is, it's actually a video module that I did and recorded. If you don't want to have to educate people yourself, you literally can go to this, play the video. It's an hour. Do it as a module. Do it as a lecture with your faculty. Do it as a lecture with your residents or your doctors in your hospital. And then on the right is a link to the Cardio OB resources on the GAPQC website. Thank you.
Good morning, I'm Jane Ellis. I'm going to be talking to you, all right, I'm not good with technology here, so, okay. It looks a little bit different. Good morning, I'm Jane Ellis. I'm gonna talk to you about the development of a maternal health and mortality reduction network here in Georgia. I'm gonna try to go through this kind of quickly because I want one of our guest here today who's going to talk to you about how that network actually works. I want to give him time to talk. I am from South Georgia. Talking fast does not come naturally to me, but I'm going to give it my best shot and see what happens. I have no disclosures to make. The objectives that we're going to go through today, which I hope will help you realize why this network may be important. We're going to review current statistics on maternal mortality in Georgia. We're going to discuss access to care issues for our pregnant and postpartum patients in the state. We're going to describe how an app-based referral network may facilitate access to care in Georgia and help improve our pregnancy and postpartum outcomes. So let me just give you a little background on how this all got started. About 3 or 4 years ago, I wasn't on call, but I got a call at 2 a.m. from a Georgia provider who practices along the Alabama border. She had been called to see a pregnant patient in a small hospital in their emergency department. This patient was a 28-year-old. She had had 2 preterm deliveries. She was about 16 weeks pregnant. She presented for chest pain and shortness of breath in the setting of a known significant cardiac condition, and she was obviously decompensating. Several cardiologists were contacted for consultation and management recommendations, but they declined to see her due to the fact that she was pregnant and had this severe cardiac condition. In fact, one of the management recommendations made to this provider was to send her to hospice. So while I was on the phone with the provider, she was telling me that the patient was decompensating and that if she wasn't stabilized quickly and moved to an appropriate facility, she was unlikely to survive. So they got her stabilized enough for transport to Grady. She was admitted for cardiology management, and our cardiology service did a phenomenal job getting this patient tanked up. She was ready for discharge after about 3 weeks in the hospital with us, and we had a good management plan in place. We kind of wanted her to stay a little bit longer, but she had childcare issues at home and said she was not able to stay. Unfortunately, we could not find a provider to take care of her once we discharged her back to her hometown. We did offer to have her come back to Grady every week or so for her OB and cardiology care. She was unable to do this due to childcare and transportation issues. She presented again to an ED at about 24 weeks, decompensating. She was transported to the University of Alabama at Birmingham. She stayed there in-house until she delivered at 28 weeks. And then she was discharged. She was unable to arrange postpartum care in her hometown, and she's been lost to follow-up. And unfortunately, this is not uncommon that OB providers have difficulty finding specialists to help assist with the care of their patients. So what do we want for our Georgia women? Well, we want the best possible maternal, fetal, and neonatal outcomes. We want prenatal care that provides a coordinated approach and a continuous risk assessment during the course of the pregnancy and into the postpartum period. We want access to all areas of reproductive and other types of care across the patient's lifespan, and we want access to other specialties for our patients as needed. How are we actually doing? Well, I'm proud to say that Georgia is getting better, but traditionally Georgia has ranked poorly in maternal and infant health due to the factors I have listed for you here. And Georgia does have one of the higher maternal mortality ratios in the country. And a maternal mortality ratio is the number of pregnancy-related deaths per 100,000 live births. Our rate for the period 2020 through 2022, which is the last published review, is 37.9. Sort of as a perspective, the CDC Healthy People 2030 program has a target MMR of 15.7, so we have a ways to go. The leading causes of our maternal deaths in this period were, the pregnancy-related deaths were cardiovascular conditions, and that's been true for the past several years, COVID-19, mental health conditions, hemorrhage, and embolism. 87% of the pregnancy-related maternal deaths during this time period were deemed by the Maternal Mortality Committee here in the state to have had some degree of being prevented. 41 rural hospitals with labor and delivery units have closed in Georgia over the period 1994 to 2023, which has resulted in large OB deserts in the state. 18 of 30 currently open rural hospitals with labor and delivery units are at risk of closure. And since this article came out in the AJC last year, 2 of those hospitals have closed. Specialists are more likely to be associated with a hospital, and we know that hospital closures can disproportionately affect pregnant patients because it disrupts their pregnancy-related care. They may have to travel, and we know that the farther a woman has to travel to receive maternity care, the greater the risk of maternal morbidity and adverse infant outcomes. Georgia has 159 counties. 82 of our counties have no obstetric services whatsoever. 15 other counties have only one provider. This map of Georgia from HRSA shows the dark areas in the state are areas where access to good care is difficult. Essentially, that's the whole state, if you ask me. Only in the Atlanta area, and then over east by Augusta and down in the southeast for Savannah, those are areas where access to care is not such an issue. And then this is a chart from March of Dimes data. I was surprised to look at it and see that 40 counties have no internal medicine providers. 65 counties in Georgia have no pediatricians. Again, 82 counties have no OBGYN services, and 90 counties have no psychiatric services. There's some other problems here that make it difficult for patients to get good care. Transportation and child care issues often make compliance difficult. Medicaid and self-pay status can be a problem. And then, as you all know, many of our pregnant patients have comorbidities such as diabetes, high blood pressure, and obesity that make it hard to find providers that want to assume their care. So what's Georgia doing to improve these outcomes? Well, the legislature extended Medicaid for 1 year postpartum. It provided funding to support maternal morbidity and mortality reduction strategies statewide, such as the AIM initiatives. Department of Public Health has encouraged hospitals to undergo their maternal levels of care designation so that we make sure our pregnant patients are in the right places for their needs. And the legislature also provided funding for blood pressure cuffs for home blood pressure monitoring with MIH and community health worker follow-up. So back to our scenario. So what do we do with our pregnant patient when she left Grady? Well, I sat down and looked at the counties along the Georgia-Alabama border. I Googled cardiologists in those counties, and I called every one of them and asked them if they would help assume care of this patient, okay? There was not one practice that took me up on my offer. And their rationale was, we don't see pregnant patients, we don't see patients with Medicaid. So I talked to Kate Boyinga at the Georgia OBGyn Society, and I said, Kate, I know there must be cardiologists out there who will help us with our pregnant patients. Do you think we could develop like a network or referral system so that we could identify those cardiologists and eventually other specialists so that we could form a collaborative relationship between OB providers and these specialists? So the Georgia OBGyn Society, or GOGS, and the Medical Association of Georgia partnered to develop a statewide maternal health referral network that would help foster collaboration between OB providers and the specialist. GOGS introduced at the MAG House of Delegates meeting in 2023 this resolution referred to as the Maternal Mortality Reduction Network Resolution, which you can read here. MAG overwhelmingly supported this resolution, and the resolution passed. And Rick Cancelier, who's going to talk to you in just a moment, has been working since this time to help get an app-based referral network set up for OBs to use to get their patients to the subspecialist care they need. If you go back and look at the GOGS June 2025 newsletter, there is a page about the Maternal Health Network here. In the newsletter, I encourage you to take a look at that, and Rick will tell you a bit more about this. Also, I thought I had my contact information here, so I was going to say, if you need me for anything, please feel free to call me. If I can help you in any way, I'll be happy to do so. So at this time, I'll turn it over to Rick. Thank you for listening. I'll be happy to take questions at the appropriate time. There's my cell phone number. Call me. Thank you.
Thank you, Dr. Ellis. Dr. Byrd's data told this incredible story about referrals not happening. And Dr. Ellis's experience kind of tells why. And it's quite fascinating for me to be here. And one of the things that, how does this work? This fine?
You're going to have to wait to go back. They got to get your slides back up.
Oh, okay. So when the slides come up, there's a letter that Dr. Toomey from the Department of Health put out that reported that in 2023, 26 of the deaths that occurred were preventable due to delayed access and poor care coordination. And I think
Green button.
the green button, the big green button. Okay, there we go. All 26 of the deaths that occurred because of the cardiac-related issues were preventable, which was quite fascinating. And it was due to lack of specialty care, cardiologists specifically, right, that were either pregnant, postpartum patients, long transfer times in rural areas, disconnected communication between providers, and issues with Medicaid. And so MAG, GOGS got together, as Dr. Ellis eloquently kind of explained, and inspired by real frustrations in getting maternal cardiology consults completed, the aim was to build a Georgia Maternal Health Initiative network, a statewide referral network, to eliminate barriers tied to getting into specialty care. And the goal was to serve OBGYNs, MFMs, cardiologists, PCPs, FQHCs, social workers, nurses, everybody providing care to these patients together in the same network, electronically in an app. It is amazing what you can do with an app today. You can order a pizza and track it on your watch. Who loses pizzas, right? Like, it is so amazing what these things can actually accomplish. But when the first challenge that we had in doing this was actually finding cardiologists that would accept the pregnant patients. This was the hardest task of all of them. And so, I mean, we, as Dr. Ellis explained, calling actual practices, decline. So what we did is we got together with Jeremy Bonfini, the Medical Association of Georgia, and Dr. Debbie Dalton, and we emailed every cardiologist in the state of Georgia 5 times with a sequence. Do you accept pregnant women, right? And the goal was to get a yes or a no, right? So that we could have a directory of cardiologists that said yes. As of this week, we have 31 cardiologists that have raised their hand, and we have decent coverage throughout the state. And we're very proud of this, right? That was the Herculean effort. And it still is, getting even more coverage throughout that area. I'm going to try to go back. Maybe someone can help me go back. There we go. So when we look at this, the first step is the directory, a searchable statewide directory. It's live. You can go to gmhi.net right now and see all the cardiologists that are listed. Several of them, hopefully you know. If you see a cardiologist that is not on that list, I'm going to ask every one of you, if you work with a cardiologist and you see someone that is not on that list, we want to know who that cardiologist is so we can get them added to the directory. It's really important to understand who are seeing these patients. One of our clients, I believe that's in the room, told us there's one underneath her, right, in the building she's in. And how amazing is that? She just refers them downstairs, right? And so we want to know who these physicians are. The next step is connectivity. It's actually not to just have a directory, it's where they can log in, verify their credentials, verify that they see Medicaid patients, verify their practice information, where they go in terms of locations. Do they go to multiple locations or one location? And be interactive with you, the OBGYNs and MFMs in the network. Curb talks, referrals, secure messaging, right? True interaction, right? Where you're able to send referrals that are tracked and coordinate visibly, right, in the network. They're all free. Directory, referrals, treat chats, right, profile management. There's no cost to any of this. It's all provided by MAG, GOGS, right? And we have Emory, Northside, Wellstar, Piedmont with physicians already in the network. And our team that really focused on patient access is providing the technology. The goal is to have coverage throughout the entire state, right, with all specialty representation, so everybody can see the patients in need and chip in with resources that they know are available and engage with each other and make sure that referrals are occurring around these patients. And we want to track the completion rates and the impact and provide extra data, right? Like, I love the screening tools that Dr. Byrd has. Those should be in the app. I love that. Like, we want to make sure that those are in there too. So we're asking you all to go to gmhi.net right now, pull out your phone, join the network, track the network, see who's in there, see who's not in there, see who should be in there, and be a part of the life-saving statewide network and help us reduce maternal mortality in Georgia. Please claim your profiles today. Thank you.
Notice how bright that light was. If I fall, just somebody pick me up. In the interest of time, there's no way I'm getting through all 65 of my slides, so sorry for that, everybody. Anyway, I'm Chad Ray. I'm the director of cardio-obstetrics at Wellstar MCG Health. And to be honest, cardio-obstetrics has really changed my career in a significant way. My life on the maternal mortality review committee really showed me where areas of focus should be. And so we took an evidence-based approach to screening, and over time developed a partnership with the Department of Public Health, and ultimately have a program that is quite robust. And we refer about 20% of our patients to a cardiology specialist. And so last year we had about 510 referrals. 380 of those patients were seen. That's one thing we haven't been able to get past is a no-show rate. But it's been great for us over the last 3 years to have more than 1,000 patients that have been seen by cardiology. And in Augusta, where we have some evidence that says we're one of the highest rates of PPCM in the country, that rate certainly seems to be going down significantly. But because of the denominator, we're ultimately going to see that it's going to take us a significant amount of time before we can see a big change in that. But I can tell you that we used to have 2 or 3 deaths a year from peripartum cardiomyopathy in our patient population, and we've had 0 since we started our program. So hopefully that remains as I tell you. Our objectives today is something that's very adjacent to cardiovascular health, but if anybody knows me, especially lately, you know that I'm a huge proponent of healthy food and nutrition, and this was very well aligned. And so I'm going to talk about our food as medicine program that is part of our cardio-obstetrics program. We'll review the scope of food insecurity, both in Georgia and in some national data. We'll talk about some health consequences that are known here to everyone, and I'll outline what our program looks like. I have no conflicts, but I do receive funding from the Department of Public Health for our cardio-obstetrics program. We're in year 4 of proposed 5, and the food as medicine program is now in year 2. The national landscape really looks pretty bleak as it relates to food insecurity. So just for some definitions to start with, the USDA defines food insecurity as insufficient access to enough food for active, healthy life, including those that have low and very low food security. And so the graph shows that about 13.5% of U.S. households, which is about 18 million individuals, have food insecurity. Food insecurity as well, let me back up and say that when we look at program and program development, we always try to frame it in the lens of eliminating inequities of health. And this is just one of many clear health inequities. And so there are clear racial and regional disparities like most things we see and focus on in maternal health. Black households have significantly higher, as does Hispanic households, for food insecurity. The rates of food insecurity nationally are highest in the South, with urban areas and rural areas both having significantly high rates compared to other areas of the state, other areas of the country. Some things that have really caused an increase in food insecurity since 2022 were the expiration of some emergency SNAP allotments and the pandemic era child tax credit, which was in 2023. Everybody knows you can't, I actually stopped watching the news as much as I possibly could because it really was bleak with rising food prices and inflation, but we all feel that. Cuts to federal nutrition programs under the current administration included a sweeping cut to SNAP benefits, more than $230 million as part of the Big Beautiful Bill that will happen over the next decade, and it'll tighten many of the eligibility rules. There's an expansion of work requirements and elimination of emergency allotments, which will likely affect about just over 3 million beneficiaries. Also, the USDA restructuring and cancellation of key programs was a significant hit for schools, and so I think you've probably heard about some significant programs that have been cut, but also food banks and community nonprofits nationwide are reporting sharp drops in their funding and a rising demand. And really, it's not just about food, but it's about nutritious food. So Feeding America is a nationwide network of food banks, food pantries, and local meal programs. The U.S. data that is highlighted in these maps here, you can see the Georgia map, but it's county specific, which is great. Overall, Georgia has a rate that's higher than the United States average at 14.9%, with Black households in Georgia having nearly 1/4 of those households have food insecurity. Households with children are about 1 in 5, and of those, 30% of those households are ineligible for federal funding. So you can see the inequity here in this map as it shows Georgia, and then it shows Black households in Georgia. You can see a significant change in the composition of the map. So this is not something that I need to highlight a lot, but I think we all know that food insecurity is linked to higher rates of obesity, type 2 diabetes, and hypertension, especially in women of reproductive age. I like to highlight it as evidence. We all know it's true, but there's clear evidence for this, and the fact that pregnant individuals experiencing food insecurity have greater risk for gestational diabetes, preeclampsia, and depression. Maternal undernutrition increases the risk for preterm birth, low birth weight, fetal growth restriction, and inadequate nutrition before and during pregnancy can cause long-term cardiovascular changes for both the mother and baby. Women in food insecure households also report worse overall health in general and more frequent emergency department use. This goes really back to something that we all say all the time. It's not maternal health, it's just simply health, and quite honestly, it does start in the kitchen. Our approach at Wellstar MCG Health for our Food as Medicine program was to say, hey, we want to have a mission and an aim, and we are really looking to improve overall health. But I think the main point for us was we wanted to start with the health of the mother, but we really wanted a culture change in the entire family. And so when we were trying to establish a program, we wanted to have a well-rounded program that would not just take into account us providing some food to a family or to a mother, either pregnant or postpartum, but we really wanted to see if we could figure a way to have a program that might change the culture of the entire family, so we would be taking care of not only this mother, but also the future generations in that family. We would begin with screening. We do this where we try to first have an intervention and then enter into a situation where we're screening for those social determinants and social drivers of health so that we have the intervention in place already by the time we start screening. And so we focused on food insecurity and nutrition literacy and barriers to access and distance to health care. And it's why really our cardio-obstetrics program has food as medicine, and it has a very robust telehealth, digital health, virtual care, whatever you want to call it. It's really a digital health platform for which nearly all of our patients are screened, and they are ultimately enrolled. When they enter into the cardio-obstetrics program, they are likely to be in our telehealth program as well, and they are screened for food insecurity already, and we are working on capacity. I told you we've had over 500 referrals this year in our cardio-obstetrics program, but we only have, in the last year, we only had 40 families that we could have in food as medicine, so we're working on that. So ultimately, it's a 6 to 7 month long program for pregnant, postpartum, and parenting mothers, where we hope we can give them not only food, but also resources and tools needed to improve the health of their family. And this is what the program ultimately looks like. We screen at ambulatory visits. We have the brochure, and then there's a QR code. For the provider can scan the QR code, and then they are contacted by the administrators for our program, and they are given an outline that would include them attending either virtual or in-person sessions at we have Augusta Locally Grown has a commercial kitchen. It's pretty awesome to have the Augusta National in Augusta, I'll just say this. And so they really have focused on sort of revitalizing an area of Augusta that's near the sort of medical district, and there's an area called the Hub. The Hub has a food bank, food pantry. It has a primary care provider. It has a Boys and Girls Club. It's just an amazing place for us to partner with. And so Augusta Locally Grown was our first partner, and they provide farm fresh vegetables. We are limited by the growing season for our farm fresh vegetables, but ultimately my wife orders HelloFresh, gets HelloFresh for us, like probably many folks in here do for some kind of food delivery service. And ultimately, we wanted to sort of make it where folks who could not have that type of experience, we would provide it for them. So there's no cost to anyone for this, as we have baked it into our programs as part of the funding. We provide childcare for those parents who come. We give food boxes, and they obtain their prescription from what we call a food pharmacy. We give weekly food boxes or bags that's nutritionally tailored to include seasonal, fresh vegetables, heart-healthy, shelf-stable items as well. We've partnered this year with a food bank that will give us non-perishable items that we are able to store in our cardiology clinic. We have a dietitian that is part of our program, and some care coordinators, case managers, and a social worker. So there's a lot of active engagement, but the mothers participate in weekly nutrition education sessions that cover a lot of topics, and I'll show you what that looks like. There's also counseling and support. We have a psychiatrist. If somebody gave me all the money in the world, one of the first things I would do was start buying psychiatrists and putting them into the workforce. It's a weird thing to say, but I think we'd all agree we need more mental health specialists. But we have one baked into our program, which is fantastic. And there's a lot of community engagement. Our medical students, as one of the largest medical schools in the country, they are always looking for opportunities, and so they participate at a very high rate to fill the boxes, engage with the parents, take care of the children when they come to their classes, that sort of thing. This is last year's sort of program. This is the food insecurity screening tool. It's very basic. I know there's no way you can read that. But we certainly can make it available to you, and it's in the presentation. But ultimately, we have classes that go from May to October, it did last year, and you can see that it includes everything from helping someone enroll in programs that would help them for resources for food, to healthy eating, to helping with WIC benefits and what a healthy plate would look like, talking about cardiovascular health, smart shopping, and fitness and exercise. We've sort of advanced a little to having a little more clean look for our patients, so they have a lot of opportunities to get some information. And you can see, I know you can't read it again, but this really goes through and talks about what the sessions would look like over the course of those 7 months. Just wanted to make sure that, that I think this is something where folks need to really understand what the evidence is. And so, we really try to take an evidence-based approach to our nutrition, and that curriculum is evidence-based because a lot of folks have a lot of ideas about what nutrition actually is and what it should look like. And to be honest, I think most folks, sort of hit close to the mark, but I think a lot of folks do miss the mark. And so we really try to focus on an evidence-based curriculum. So some data just from our program. We have, and we'll eventually publish this data, but baseline data from screening for all social drivers of health showed that we have high rates of nutrition insecurity and lots of patients with elevated blood pressure. There's low physical activity and poor diet scores, and our barriers tend to be exactly what you would think they would be, which would be transportation, literacy, and childcare. Our anticipated outcomes is increased self-efficacy, and we are definitely seeing a difference in our cardiovascular key performance indicators and measures, and we're looking at their dietary behavior post-program. So we'll have data for that in the years to come, and we're looking at their physical activity levels as well. So my call to action is to say that we just had an idea that we had no idea what it would look like, but we knew that food insecurity is a root cause of maternal morbidity. I think we all know that it contributes significantly to cardiovascular health. So I would say start small, partner locally, and then measure your impact. Obesity-related conditions like hypertension, diabetes, heart disease drive these preventable maternal deaths, and so our clinical care must confront food access and nutrition. Governmental agencies are finally pushing for education to reduce ultra-processed foods and emphasizing a plant-forward or plant-slant diet with whole foods. And so now we have some national guidance. We just need some local execution. And quite honestly, if we fail to address nutrition, we will continue to widen the racial, geographic, and economic gaps for maternal outcomes. And so I like to think that food is foundational and equity really starts at the plate. Thanks.
Thank you so much to our wonderful panel. Does anyone have any questions? No questions. Okay.
This is actually for Dr. Ray. So first of all, that's amazing. Thank you so much. It's more a question and maybe a thought for you, and I'm curious where you would think about this. We recently published data where we geocoded the entire state of Georgia and looked at food deserts based on the census tracts. And it was my fellows study. And it was presented at SMFM last year as an oral. And of course, we thought food desert would be associated with worsened nutrients. And we actually had micro and macro nutrients. And the interesting thing is, it didn't matter if you lived in a food desert or not. Your micro and your macronutrients were significantly poor in pregnancy. And so to me, I wonder, and maybe I'm bringing this up to the group here, is I think beyond even food insecurity, I think there's a bigger problem we have here, which is food education. And I wonder if there is a way, as a state, we can think about that as an initiative, because it's not about how close you live to the Whole Foods. It's about, are you actually using it? And we recently actually now also did data on outcomes. And the sad part is, it doesn't matter again on your census tract. Your outcomes are the same because probably your nutrients are the same. So I think this is amazing, but I almost also want us to focus and think one step further, that it's not just the food insecurity based on what we formally define as food insecurity based on DPH or census tracts or what we're doing, but it seems like food insecurity could affect anyone if you're not able to secure proper food, if you don't know how to secure proper food. And so I'm curious, what are your thoughts on that with this program?
This thing's giving me 4 minutes, so I'm not going to have to, we'll talk later. But I'll tell you that, there was a reason why our program is so balanced in providing food, but more importantly, it's that entire program. Most folks opt out when they're screened and contacted because of the fact they don't want to put the work in to actually learn to be, to increase their nutritional literacy. And so I agree with you 100%. I mean, there's no question that all the way across, the decision that someone makes about what they're going to put in their mouth to eat, it does not necessarily depend on whether or not you have access to food or not, right? Obviously, those who have true food insecurity, especially very low food insecurity with hunger, those patients we're definitely wanting to provide food to. But the food is the carrot. And so that's how we're sort of capturing these individuals who we know we're going to make a difference in some of their families. But again, our mission was to educate the leader of that family to hopefully impact their children so they were not putting, whatever ultra-processed, quick, easy, cheap, garbage food that we all eat from time to time, and eliminate that from their diet.
I'm going to have a question for Suchi later on.
Thank you for all of that. They were all wonderful talks. And Chad, I just want to lift up what you guys are doing. I think it's fabulous. I brought this up in my inaugural speech because food as medicine is something that we don't teach our residents. We don't teach medical students. But food is the gateway to all healthy care. And it's upsetting to me that we watch as society continues to get obese and heavier and heavier, and all these complications that we're trying to prevent would not exist at the same rates if we had a much healthier population and the food source is the problem. And I love hearing that because I totally agree that it doesn't, food insecurity is a big issue, but even in places where there's copious amounts of healthy food available, we're not teaching our patients properly to eat the right foods during pregnancy. And I think we need to do better nationally at getting guidelines out, and the reality is the guidelines that exist, I mean, every day there's a new diet out, every day there's a new way of, I mean, and no one knows what is right and what is wrong because TikTok is educating everyone now, and so we need to do a better job nationally of providing proper guidance on all that. So thank you for the work you're doing. I think that's a program we should be, elevating across the entire country.
Thank you. And I'll just say that one of the biggest food deserts that I had seen was the hospital that I work in. And I would like to just make a push. When I say start small, start local, right? Start with all of the individuals that are taking care of our patients. We should role model good health, and that is, a part of that is nutrition. And so I really have some beef with, and the hospital knows it. I am an associate chief medical officer and sit in the C-suite and talk about it a lot. They're tired of me. But at the end of the day, the food that we provide our patients in-house should be off the farm. We talk about it in, terms of GOGS packaging versus, General Mills.
Hi, thank you for that. I really enjoyed this session. Sandra Brooks, CEO of ACOG. In my former life in Philadelphia, we worked with our health insurance Medicaid provider and one of the food banks that had also a food delivery service, and we're able to work to develop a food as medicine prescription. So our physicians were able to write a prescription for referral to the medically tailored meal program that did encompass a lot of what you're talking about, what was tying in the health system piece. So I think going forward, particularly as these nonprofit health systems have their community benefit piece that they have to manage, it's certainly a potential, way of tying, the food as medicine, providing the prescription, working with community health workers, and then also working with the medically tailored meal providers in the community that you can then ideally track the results within the health system. So I really appreciate what you're saying because, it's grassroots efforts like this across the country, I think, that are going to help us make an impact. And then particularly about the work that you all are doing with the screening tools, we'd love to, catch up later because we're obviously trying to amplify this work throughout the country, which is, and I think we should be going to the, American Heart Association, the Association of Black Cardiologists, all the subgroups so that we're not having to physically you're not having to physically email every single cardiologist to see who's going to step up and help us tackle this. So I'd love to partner with you to see how we can take this even broader. Thank you.
I'd also like to quickly offer, too, that for all of our Medicaid patients in the state of Georgia, a House bill was passed a couple of years ago, Healthy Mothers, Healthy Babies. You should visit the Phillips booth outside. For your patients that are pregnant, that are on Medicaid, free of charge, there is a blood pressure monitoring and a diabetes monitoring program. They will give your patients blood pressure cuffs. They'll mail them to them. They are linked to a digital platform, which is manned by a bunch of nurses who I have taught to do the cardiovascular screening. They will provide this for 6 months, 3 months up to delivery, and then 3 months postpartum, where they call the patients, the blood pressure. They don't have to have Wi-Fi. These blood pressure cuffs are already digitally linked to the platform, but it is free for your patients, and it is still ongoing with the grant for up to 2 years from now. So please visit that booth. If you want, I have a QR code that you can scan to get all the materials. It's very simple for your care source, Medicaid, Peach State patients, free of charge, blood pressure cuffs, and diabetes screening.
Dr. Brown, would you like to ask our last question, please?
Yeah. Well, first of all, I want to thank you for the work that you're doing, number one, because this is such a big space. And I want to kind of do a little visit of history because Dr. Oyey's whole presidency was designed around cardiac disease and pregnancy, as you know. And then when I was president, we wrote an advisory with the American Heart Association on the relationship between gynecologists and cardiologists. So all this history of what you all are doing now with cardio obstetrics just needs to be pushed out as women have, this is the leading cause of women's death. So I applaud the work you're doing. It needs to get to the general OBGYNs in those communities. And with our access to care issues being what they are, what you're doing at this level needs to be spread throughout every state. So we're here. We just finished writing the perinatal heart failure document for the cardio-obstetrics group. That's going to be coming out a little later this year. And it's really focused primarily on, as you know, the leading cause for is cardiomyopathy. And so keep up the good work, great work, and we're here to help you any way we can.
Yeah, with so many ACOG leaders here too, I'd like to just say, I'll make my own plug, right? The rate limiter here is the cardiologist in many ways. So what we have seen at Medical College of Georgia is that we, in our program, there was interest. I could never have had a program, especially the program that I'm so proud of, without my cardiology partner. And the reality was that he was the one who was comfortable. And now in the fellowship world, he is training the folks that will ultimately go on and be, comfortable with taking care of pregnant and postpartum patients. So from an academic standpoint, we need to get with the cardiologists to make sure that they're training individuals that are comfortable, because that is it's a non-starter if we don't have that workforce in place.
And I want to make one comment too. I had twisted her arm a little bit. I echo what Chad said. It's been a heavy lift getting cardiologists on board, and I know a lot of them tell me when I send the patient to them for review, they'll call me back and say, do you know this patient's pregnant? We don't see pregnant patients. I'm like, I'm her MFM, I have a little bit of an idea that she is pregnant. And also the cardiology clinic at Grady, where I work, was directly across from the OB clinic. You walked out of OB into cardiology. I was over there so many times saying, can you look at her EKG? Can you do this? Can you see this patient? Blah, blah, blah. Part of them moved up to the 3rd floor, part of them down to the 1st floor. I take that very personally. I think they got tired of me and they decided this is the easiest way to get rid of her. So we still got a lot of work to do, and I'm hoping our cardiology colleagues are going to recognize that and really partner with us.
Thank you.
Thank you so much to our panelists. Give them a round of applause.